The low sodium problem. Hyponatremia means low sodium in the blood, specifically a serum sodium below 135 milliequivalents per liter. This isn't just a lab number, it signals a disruption in the body's fluid and electrolyte balance. Sodium is the main electrolyte outside our cells, crucial for nerve function, muscle contraction, and blood pressure. When sodium drops, water shifts into cells, causing them to swell, especially dangerous in the brain, where swelling leads to cerebral edema and increased intracranial pressure. The speed of sodium decline matters. Slow drops may cause mild symptoms, but rapid drops can be life-threatening. Hyponatremia is usually a problem of too much water relative to sodium, a water balance disorder. This distinction is key. Treatment isn't just about giving salt, but understanding why the water-to-sodium ratio is off. Is the body retaining water, losing salt, or both? That's the first question to answer. Recognizing this core concept will guide your diagnosis and management. Hyponatremia is common and can be mild or a medical emergency. Understanding the underlying cause is essential for safe and effective treatment. Let's break down how to approach it. To fix hyponatremia, start by assessing the patient's volume status. Are they overloaded, dehydrated, or normal? Hypervolemic hyponatremia, too much water and sodium, but more water, seen in heart failure, cirrhosis, or kidney disease. Look for swelling, edema, or fluid in the lungs. Hypovolemic hyponatremia, loss of both water and sodium, but more sodium lost. Think dehydration from vomiting, diarrhea, or diuretics. Signs include low blood pressure and dry mucous membranes. Euvolemic hyponatremia, normal volume, but extra water dilutes sodium. The classic cause is SIADH, where excess antidiuretic hormone makes the kidneys retain water. Other causes include severe hypothyroidism or adrenal insufficiency. Sorting patients into these categories is the foundation for diagnosis and treatment. Remember, volume status guides your next steps. Hypervolemic, think fluid restriction and diuretics. Hypovolemic, replace both salt and water. Euvolemic, identify and treat the underlying cause, often with fluid restriction. Hyponatremia's symptoms are mostly neurological due to brain cell swelling. Mild or chronic cases, subtle symptoms like headache, nausea, fatigue, confusion, or unsteadiness, especially in older adults. Moderate or acute drops. Worsening confusion, drowsiness, agitation, muscle cramps, vomiting. Severe rapid drops, seizures, respiratory arrest, coma, or death. This is a medical emergency. Always consider how quickly sodium has fallen. Recognize red flags and act fast in severe cases. Early recognition saves lives. Diagnosing hyponatremia is detective work. Start with the low sodium lab result, then assess volume status, wet, dry, or normal. Next, check serum osmolality. Most true hyponatremia is hypotonic, osmolality 275 mos/mkg. If osmolality is normal or high, consider pseudohyponatremia or hypertonic causes like high glucose. For true hypotonic hyponatremia, order urine sodium and osmolality. Low urine sodium, 20 mg/L, suggests the kidneys are conserving salt, seen in dehydration. High urine sodium and high urine osmolality, especially with normal volume, point to SIADH. In SIADH, the kidneys inappropriately retain water and excrete sodium. Always put together the clinical picture: volume status, labs, and underlying conditions. This systematic approach leads you to the right diagnosis. Don't skip steps. Each clue matters. Accurate diagnosis is the key to safe treatment. Treatment depends on severity, cause, and whether it's acute or chronic. Severe symptoms, seizures, coma, give hypertonic 3% saline to quickly raise sodium and reduce brain swelling. Just enough to stabilize, not to normal. Mild or moderate symptoms, treat the underlying cause. Hypovolemic, give isotonic saline to restore both salt and water. Hypervolemic, restrict fluids and use diuretics to remove excess water. Euvolemic, SIADH, fluid restriction is first line. Sometimes salt tablets or Vaptans are needed. Always search for and address the underlying cause: medications, lung disease, or hormone problems. Tailor your approach to each patient. Never rush correction. The golden rule: correct sodium slowly. Rapid correction can cause osmotic demyelination syndrome, ODS, a devastating, often irreversible neurological injury. ODS results from brain cells shrinking too quickly after rapid sodium rise, leading to paralysis or locked-in syndrome. Limit sodium correction to no more than 8-10 mg/L in 24 hours or 4-6 mg/L for high-risk patients. Monitor closely and adjust as needed. Always reassess volume status, labs, and symptoms. Careful, stepwise management prevents harm. Master these principles to safely manage hyponatremia and protect your patients.